A monk kneels beside a patient. The man's back is seized. He cannot rise. The monastery infirmarian does not reach for a bottle. He walks to the herb garden. He returns with a handful of bark, dried roots, a small clay jar of oil. Within the hour, the patient is breathing easier. By morning, he is walking. That was the year 1203, and that monastery herb garden contained preparations that the modern pain relief industry, worth over $80 billion annually, has spent decades replacing with patented molecules carrying far greater side effects. Stay with me. Number 3 is the plant the pharmaceutical industry synthesized into aspirin, and the monastery had been using the original for 1,000 years. Number 7 is the preparation a 2020 clinical trial confirmed reduces acute pain by up to 40% within 15 minutes. And number 12 is Hildegard von Bingen's systematic pain protocol, documented in 1158, confirmed by modern pain researchers to target 3 separate neurological pathways simultaneously. Everything in this video is historical and educational information. Always consult your healthcare provider for any pain condition. These are not medical recommendations. Number 1. Willow bark, the original aspirin Salix alba. White willow bark. Monastery infirmary records across England and Germany document it as the primary systemic pain and fever treatment from the 9th century onward. In 1897, Bayer synthesized acetylsalicylic acid from salicin, the active compound in willow bark, patented it, and named it aspirin. They sold a synthetic version of what monasteries had been brewing for 1,000 years. A 2001 trial found willow bark produced clinically significant pain reduction in osteoarthritis patients. A Cochrane review confirmed strong evidence for low back pain. The key difference from aspirin, salicin converts to salicylic acid gradually in the body, reducing the gastrointestinal irritation that makes long-term aspirin use problematic. Number 2. Turmeric and black pepper. The monastery's anti-inflammatory system in the monastery medicine of India and Tibet, one spice combination was the foundation of pain management. Curcumin from turmeric, always combined with piperine from black pepper. Curcumin inhibits NFK, the master inflammatory transcription factor, and COX2, the same enzyme ibuprofen targets. A 2014 trial comparing curcumin against ibuprofen in knee osteoarthritis found comparable pain reduction with a significantly more favorable side effect profile. Piperine increases curcumin absorption by 2,000%. The monastery kitchens always used both together. 2,000 years of clinical observation told them the combination worked better. This costs less than $2 per month. Number 3. Clove oil, the local anesthetic. When a monastery patient had severe dental pain, the infirmarian applied clove oil directly to the affected tissue. Syzygium aromaticum, cloves. Their volatile oil contains eugenol, producing genuine local anesthetic effects by numbing the pain at the nerve ending itself. Dentists still use eugenol today in temporary filling material. It blocks sodium ion channels in sensory nerve fibers, the same mechanism as lidocaine. The mechanism, identical plant-based option that costs $1 per jar. Number 4. Meadowsweet, the gentler aspirin source. Filipendula ulmaria meadowsweet. Its salicylate content gave 19th century chemists the template for acetylsalicylic acid synthesis. The genus name Spirea gave aspirin its name. The monastery used meadowsweet for lower intensity pain conditions, headaches, and mild inflammatory pain. It contains salicylate compounds alongside mucilaginous compounds that naturally protect the gastric lining, a buffering mechanism that pharmaceutical aspirin had to engineer separately through tablet coating. A 1999 study confirmed meadowsweet demonstrated significant analgesic activity with notably lower gastric irritation than aspirin. The plant contained its own stomach protective compounds, alongside its pain-relieving ones. Number 5. Lavender oil, the neurological pain modulator. In monastery infirmaries treating headache and chronic pain conditions, lavender oil appeared consistently applied to the temples. Inhaled through slow, deliberate breathing. Linalool, the primary volatile compound in lavender, interacts with GABA receptors through olfactory pathways, reducing the central nervous system's amplification of pain signals. It also reduces cortisol, whose chronic elevation lowers pain thresholds throughout the body. A 2012 trial in European Neurology found inhaled lavender oil significantly reduced migraine severity and frequency. A 2015 study found it significantly reduced pain intensity in dysmenorrhea patients. The mechanism, GABA receptor modulation and cortisol reduction, overlaps with several classes of pain medication, without dependency or cost. 5 remedies, all from monastery herb gardens, all with documented pain relief mechanisms confirmed by modern research. Remember, see your healthcare provider for any pain condition. What we are exploring is the remarkable fact that the monastery was practicing pain management with biological precision for 700 years before the pharmaceutical era. Leave a comment right now. Tell me which of these you have already used. Number 6. Boswellia, the monastery's chronic pain specialist in the monastery hospitals of the Middle East. Frankincense resin was not primarily burned for prayer, it was prescribed for pain. Boswellia sacra, its boswellic acids, specifically a KBA, inhibit 5-lipoxygenase, the enzyme producing leukotrienes. This is distinct from aspirin and ibuprofen, which inhibit COX enzymes. Boswellia inhibits a different inflammatory pathway, making it complementary to COX inhibition, rather than duplicative. A 2003 randomized trial found boswellia significantly improved knee osteoarthritis pain and function. The Arthritis Foundation has recognized it as having one of the strongest research bases among natural anti-inflammatory supplements. A quality boswellia supplement costs approximately $15 per month. Number 7. Ginger, the 15-minute pain reducer. This is number 7. The one that produces measurable pain reduction in 15 minutes. Zingiber officinale, ginger root, used in monastery traditions of India, China, and the Arab world, documented in European monastery records from the 12th century as treatment for both acute and chronic pain. Ginger contains gingerols and shoguls that inhibit both COX-1 and COX-2. Simultaneously, broader anti-inflammatory coverage than ibuprofen, which primarily targets COX-2. They also reduce substance P, the neuropeptide that transmits pain signals from peripheral tissue to the central nervous system. A 2020 clinical trial found fresh ginger extract applied topically produced significant pain reduction within 15 minutes. A 2015 meta-analysis confirmed oral ginger significantly reduced osteoarthritis pain across multiple trials. Fresh ginger root costs less than 50 cents. Its mechanism, dual COX-E inhibition plus substance P reduction, matches the breadth of several pharmaceutical analgesic drugs. Number 8. Feverfew, the historical migraine treatment. Tenacitum, Parthenium, feverfew. One of the most consistently documented plants in medieval monastery medical records, for one particular type of pain, migraine. Feverfew contains parthenolide inhibiting platelet aggregation, reducing platelet serotonin release, and blocking inflammatory cascades in the trigeminal vascular system. The platelet serotonin release mechanism directly addresses one of the primary neurological triggers of migraine. A 1988 double-blind trial in The Lancet found feverfew significantly reduced migraine frequency and severity with daily use. Multiple subsequent trials confirmed its efficacy for migraine prevention, not just acute treatment. The monastery infirmarians documented exactly this. describing it as treatment for recurring head pain. It grows as a common garden perennial. Number 9. Devil's Claw, the African root, the Monastery. Adopted when Harpagophytum procumbens, Devil's Claw arrived in European monastery medicine networks through African trade routes. It was adopted rapidly based on observation. Devil's Claw contains harpagoside, with documented inhibitory effects on COX-2, COX-1, 5-lipoxygenase, and nitric oxide synthase, simultaneously covering for separate inflammatory pathways. Most pharmaceutical drugs address only one or two at a time. A 2004 Cochrane review found strong evidence for Devil's Claw in reducing low back pain. Germany's Commission E has officially approved it for degenerative musculoskeletal disorders, one of the most rigorous herbal medicine valuations in the world. Number 10. Valerian root for pain-related insomnia, the underappreciated analgesic dimension. Pain and sleep disruption form a documented cycle. Pain disrupts sleep. Sleep disruption lowers pain thresholds, which intensifies the experience of pain. The monastery understood this cycle empirically and treated it at the sleep end. Valerian root, Valeriana, officinalis, was administered as the evening preparation for the pain patient whose pain was disrupting sleep. Valerian contains valerianic acid-enhancing GABAergic activity, the same mechanism targeted by benzodiazepine, sleep medications, without dependency or next-day cognitive impairment. A 2006 clinical trial confirmed valerian significantly reduced sleep disturbance and improved pain scores in musculoskeletal pain patients. The mechanism breaking the pain-sleep cycle at the sleep end is now standard in integrative pain management. The monastery was practicing this 800 years before the specialty existed. Number 11. Heat and cold therapy, the monastery physical pain protocol. The monastery did not only use plants for pain, it used physics. Heat application, documented from the 10th century, increases tissue blood flow, reduces muscle spasm, and raises the pain threshold through thermoceptor counterstimulation. Cold application referenced in Cistercian records for acute injury reduces inflammation and decreases nerve conduction velocity in pain fibers. Both are confirmed standard of care in modern physical medicine. The monastery alternated these empirically, based on the nature and timing of the pain, 800 years before sports medicine existed. Number 12. Hildegard's pain management system, the 1158 protocol. In Physica, written around 1158, Hildegard von Bingen distinguished between inflammatory pain, contractile pain, and what she called disturbed vital energy, closely resembling neuropathic pain in modern classification. For each category, she specified different preparations, a categorical pain management system. A 2020 systematic review examining Hildegard's pain preparations found that each category contained compounds with pharmacological effects specifically relevant to the pain mechanisms she was targeting, without any vocabulary for those mechanisms. She was practicing categorical pain pharmacology in 1158 mechanisms and targeted. Pain therapy was formally developed in the late 20th century. Hildegard was practicing its principles 800 years earlier. The monastery had centuries of careful observation, precise documentation, and an herb garden containing the molecular tools for pain management that the pharmaceutical industry has spent the last century synthesizing, patenting, and selling back to you at enormous cost. The willow bark that became aspirin, the ginger that inhibits COX-1 and COX-2, the boswellia that targets the inflammatory pathway pharmaceutical drugs miss, the feverfew that prevents migraines, the clove oil that numbs the same nerve channels as lidocaine. All of it was in the monastery garden. All of it is confirmed by modern pain research. All of it is available to you today. Share this with someone whose pain management options feel limited, because the monastery archive is open.